practice question, and I'll be taking practice question number 6. Sorry, my slides are. Okay. The question says, a 32-year-old uneducated security man. The patient is a known epileptic presenting to your clinic with a history of recurrent seizures. He claims to be taking his medication regularly, though with worsening symptoms in the last 8 months. He also takes alcohol. My task this morning is to counsel the patient on his disease and treatment, to determine reasons for worsening symptoms, as the simulator is concerned about losing his job and has not been taking his twice daily medication because he feels sleepy. Also required to state the relationship between alcohol and carbamazepine, and 4 ways of monitoring drug compliance, and to mention the advantages and disadvantages of this method. Okay, so number 1 question. I don't know if Dr. Go is in the house. Please, simulator.
Did you talk to somebody as they are?
I'm available.
Yeah, no problem.
Yeah.
All right.
Anybody can go.
I'm available now.
Okay, all right.
I'm available
Okay,
now.
Okay, thank you. Thank you, sir. Okay, good morning, sir.
Good morning, doctor.
Okay, how are you today, sir?
I'm fine.
Okay, all right. My name is Dr. Cassidy. I've been asked to discuss with you about your health condition. Is that okay with you, sir?
Yeah, that's fine, Dr. Cassidy.
Okay. Before I proceed, actually, is there any particular language you prefer we use? Or can we go with English? Hello? Hello? Hello, please, can I be heard? Hello?
Yeah, we can hear you. We can hear you.
I think it's
your
locked out. Okay.
Okay, please, I think someone else can come.
Can anybody, even when you didn't practice?
Anybody can volunteer, please.
All right.
Anybody can volunteer.
I will simulate.
Okay, thank you. Okay. Okay, thank you. Sorry, I will begin again. Good morning.
Good morning.
Sir. Okay, how are you today, sir?
I'm fine, sir.
Okay, so my name is Dr. Cassidy. I've been asked to discuss with you about your health condition. Is that okay, sir?
Yes, doctor, it's fine.
Oh, okay, all right. Please, may I know your name?
I'm Mrs. Okoro.
Okay, Mrs. Okoro. Okay, Mr. Okoro, can I address you as Mr. Okoro? Is that okay with you?
Yes, sir.
Okay. Okay, I was told you are 32-year-old. Is that correct?
You're right, doctor.
And you are a security man.
Yes.
Okay, please, where do you work?
Man, yeah. I work in a hospital.
Okay, in a hospital. Okay. All right.
Please,
yes. Okay, is there any language you prefer that I would use in this discussion? Or is it okay with you?
I prefer Yoruba.
Okay, in this case, I think I will need a translator, please.
Okay, we can discuss in English.
All right, thank you. Okay, please, did you come with anyone today?
No, doctor, I came alone.
You came alone, okay. Is anyone you want to be here while we discuss?
I'm fine. I can take 2 minutes.
Okay. Are you comfortable with here, or do you prefer we go somewhere else?
This place is fine, doctor.
Okay. I was told you have a health condition called epilepsy, and is that correct? Do you know what epilepsy is?
No, sir, I don't.
Okay. But I would like to know, have you heard about it before?
No, sir, not.
You have not heard about epilepsy? Okay.
No, sir.
But what can you tell me about your health condition, as in why you're here today?
Yeah, all I know is that sometimes I just something happens to me. I don't know, something just happens and I start checking. People say, because I don't really know myself when it's happening. It does happen. My whole body will start checking, and I will not know myself. People will explain what happened.
Okay, thank you. Sorry about
Called
that.
it convulsion. They called it convulsion that
Okay.
time.
Okay, sorry about all that experience. Okay, would you like to know more about this health condition, or we want
Yes,
to know a little about it?
no, I want to know. I want to know what is wrong with me.
Okay, all right. Okay, now this condition is called epilepsy. It's actually a condition that starts from the brain because of some abnormal electrical activities that involves the neurons, or what we may regard maybe as the wires in the brain and all that. So it tends to occur from time to time, and has this because of some excessive discharge of these activities, and this will result to shaking, like you said, shaking of your body, and actually may result to you losing conscious. At that point, you may not know when you lost conscious, and then except some people may tell you this is what happened, and it may involve some part of your brain, or it may involve the whole part of your brain. And when it involves one part of your brain, sometimes it may result to you having one side of your body shaking, or it will involve the whole part of your brain, you now involve your whole body shaking. And this may last for occur for like 1 to 3 minutes, and it has this it can actually recur from time to time if the proper thing is not done. And like I said earlier, when it occurs, you may lose conscious. Sometimes you will lose conscious, and you will not, when you wake up, you will not know exactly, you may be confused and not know exactly what happened. And even when it occurs, sometimes you may have bite your tongue, or in some conditions, in some cases, you may have some body pains because of this excessive shaking of your body. Now, before it occurs, sometimes we even know that it's about to happen. We call it aura. Like in some cases, we have some feeling of abnormal sensations, maybe even some strange smell that you may perceive, or even begin to feel somehow in your stomach, or sometimes we have some flashes of light on your face and all that before it actually happens. Now, when it happens, it can now lead to this thing we call convulsion. I don't know if you understand what I've said so far.
Doctor, you said too many things, so but I think I got most of what you said.
Okay. Okay, got what? Okay, thank you. Okay, now can I go ahead?
Ibe.
Yeah, go ahead, sir.
Ibe.
Okay. Hello,
Dr.
okay,
Ibe,
yes, ma'am. Morning.
you use 10 minutes. Let's say with all the drama, you use 5 minutes. You have 2 minutes more to round up. Then you answer your other questions. Dr.
Okay, thank you.
Yahaya, please time you.
I'm timing now already.
Okay, so many things can actually cause this problem. Sometimes it may just occur. Maybe we don't even know what causes it, or it may occur from because of some occur development while you are growing up, and also it may occur because some changes in your brain. Like, for instance, if you actually have the brain tumor, or you had injury in the past that caused some abnormal healing in your brain, or it may actually result from some changes in your body, like if you have a kidney problem or have a liver problem. So these are actually things that can cause it. Or even in case of alcohol, if you take alcohol and you're trying to withdraw, so you have alcohol withdrawal, what we call alcohol withdrawal syndrome. Even some people that actually have stroke can actually have this problem. Most of it's not really peculiar to men. It can also occur in even female, even in any age. So it can occur in young people, it can in older people. So in terms of other things that can cause it also, it may also be from other infection in the brain. So these are the causes that can cause it. Now, in terms of diagnosis, we want to find out the person that have this problem. Of course, like I said, when it happens, you will not know exactly what happened. So some people, they have to tell you, this is what happened, this is what we experienced.
Please come on because of fire.
Doctor, what about my job? Will it affect my job?
Yes, it affects your job, especially if you are not taking your drug regularly. So you may have this convulsion occurring from time to
I
time.
take my drug, I take it. The way they told me to take it is the way I've been taking it.
Okay, but do you have any problem at taking those medications?
I don't have any problem. Sometimes it makes me feel drowsy, but I still take it.
Okay, but I was told that you take alcohol also.
Yes, doctor, I take alcohol.
Okay, so this alcohol can affect you also. Some if with this, especially when you take this some of those drugs, it can actually make you to even feel more sleepy or worsen the side effect of some of those drugs. So, and alcohol can even make someone drowsy. So this drug can make one drowsy. So both of them can actually worsen this effect. So it's advised that you have to stop or cut down alcohol, possibly stop this alcohol, so that this drugs will work, and also you will not have this much side effect. Is that okay with you?
Yes, doctor, I got you. That's what you said.
Okay. So there are some treatments that, of course, you're already on treatment.
You have 1 minute left.
So when you do all those things, then you actually help in controlling these problems, and you won't have a recurrence of this problem. And most times, if you're consistent with this drug for a long time, maybe a time when this tissue may be kind of a convulsion free, and you may have to start bringing down this drug, and subsequently you can even stop this drug if everything goes on very well. So I don't know if you have any question or any or other concerns you'd like us to address.
I don't have any question. Just that I feel stopping alcohol will be a bit difficult for me. How will you advise? What will you advise me to do?
Okay.
What do you advise me?
It's already time. It's already time.
Okay, thank you.
All right. All right.
Okay.
Thank you, Dr. Cassidy.
That proceed to the next question. The other question.
Okay, sorry. Yeah, go ahead.
Okay. Thank you, Ma. Then the possible reasons for worsening of this patient's symptoms may include the poor understanding of epilepsy. As we can see, patient doesn't know much about this, and then non-adherence also can cause this, because patients feel sleepy. So most time he may not take these drugs as advised. Then drug alcohol interaction, and also the drug side effects of this drug can actually make patients not to be adhered to these drugs, thereby worsening the symptoms. Now, relationship between alcohol and carbamazepine. It said that carbamazepine and alcohol are inducers of cytochrome P450, though alcohol is said to be lesser hepatic enzyme inducer. But however, when you have carbamazepine with alcohol, it can actually cause increased metabolism of alcohol into its active component. And carbamazepine known to be hepatotoxic, and also the alcohol can also worsen this effect. And also because of the side effect of carbamazepine, alcohol can also potentiate these side effects such as drowsiness dizziness, and even poor concentration. Now, 4 ways of monitoring drug compliance in these patients and also advantages of each method. Number 1 is the pill count. This measures the difference between the dosage units that initially dispensed and the number that's remaining on a return visit. And the advantages here include that they are said to be the easiest method for assessing patient adherence. The advantages that are said to be that it may underestimate adherence in older populations, and also the pattern of non-adherence are often difficult to discern with a simple count of pills on a certain date, weeks to months after the prescription was filled. The second method is biological assays. This includes the use of biological markers and also the therapeutic drug levels. This measures the concentration of drug and its metabolites in the blood or urine of a patient. The advantages here, they are more sensitive and specific, and they have gives a direct morphological indicators of medication adherence. However, limitations are because of the feasibility of these techniques may be limited because of high cost, and there are also individual pharmacokinetic variations of this drug. There are also legal and ethical issues when you use this method. Third method is electronic monitoring. This is through medication event monitoring system, which allows assessment of the number of pills missed during the period as well as adherence to a dosing schedule. The advantages here are that when supplemented with other methods of measurement, it enhances compliance monitoring. But because of cost, the use of this method may be limited. The fourth method here is the scaled questionnaire, which is a structured interviews using highly skilled and refined techniques like what called the Morisky scale, which is a validated scale that estimates the risk of medication non-adherence. It addresses barriers to compliance and permits healthcare providers to reinforce the positive adherence behavior. The advantages are that it's relatively simple and economically feasible to use. It actually solicits more information regarding situational factors that may interfere with the medication adherence, like forgetfulness. It may be inapplicable in some mentally deranged patients. So that is actually the end of the questions. Now, let's quickly look at the adherence versus compliance. Actually, in the past, Dr. Ham actually said a few things about this, and also some clarification from Chitu. But adherence, however, is defined as the active, voluntary, and collaborative involvement of the patient in a mutually acceptable course of behavior to produce a therapeutic result. WHO actually defined it as the extent to which a patient's behavior corresponds with agreed recommendation from a healthcare professional. So the concept of adherence is broadly viewed as related to instruction concerning the medicine intake, use of medical devices, diet, exercise, even return for scheduled appointment. But while compliance is actually the conscious effort to use drugs in a manner that is prescribed, it is the extent to which all individual behavior coincides with medical and health advice, and understanding how the medication should be used with sufficient positive motivation and intention, looking at the perceived benefit. Now, it is said to be more of a passive behavior that is dictated by a patient who is simply following instruction given by a health provider. Now, actually compliance can be categorized into 4. This is actually based on acceptance of diagnosis and treatment initiation. We have non-compliance. These are those who do not accept the diagnosis but need treatment. They have partial compliance, those who accept diagnosis and treatment but cannot fulfill the recommended actions sufficient to reach targeted improvement in their health. They also have over-compliance. In this case, a patient is doing excess over the targeted improvement. Then you have adequate compliance, those who follow health advice adequately to improve their disorder. Now, you also have other medication taking behavior, have concordance, which is a consultative and consensual course of therapy partnership between the consumer and their doctor. It's actually a process by which a patient and clinician make decisions together about their treatment, and it's basically involve the patient in the treatment process actually, and this helps to improve this compliance. We also have other terms, another type of adherence, which is called persistence, which is patient's ability to continue medical advice for the intended course, which may range from few days to lifelong. Now, other methods of assessing medications, these are categorized into direct and indirect methods. Direct methods are directly observed therapy, measurement of the level of medicine or in the blood, which like I said, has biological access. And then you have, though they are said to be more robust than the indirect method, they have limitations, like I said earlier. For instance, patients may hide pills. In terms of directly observed therapy, these patients may hide pills in their mouth and then discard them later, even though you may ask them to open their mouth. There are some patients that can actually hide some of these pills and may not be able to locate where they are. And also, variation in metabolism can also affect the serum level in terms of the therapeutic drug level. Now, also, they are said to be not practical, especially for routine clinical use. The indirect methods of adherence assessment include patient questionnaires, self-report, pill count, rate of prescription refuse, assessment of patient clinical response. The most commonly used indirect methods include the patient self-reporting, which is self-count, and also pharmacy refuse. This is more common. Like patient comes to clinic, asks, have you taken your drugs? If patient comes to the drug, you want to count how many have you taken in the last 1 week, last time I saw you, and all that based on the duration that was given. Now, the Moresky scale is a commonly used validator for item self-reported adherence measure that is predictive that is predictive adherence. That's why you use them in many comorbidities, hypertension, control of blood pressure, even in epilepsy, like an index patient, or even also in cases of rheumatology, or even in asthma. So they have a different way they are actually designed to suit these comorbidities and also different subspecialties. That's the end of my presentation. These are my references. Thank you for listening.
Thank you, Dr. Kasidi, for this very good presentation. We must acknowledge and appreciate your efforts. Despite not being well yesterday, we were able to come up with this. So thank you, we appreciate. The floor is open for contributions. So any contribution from the counseling to the other aspect of the question? Okay, let's see if there is a chat. Okay, let me read out the chat before people before the contributions. Dr. Mahmoudi said he's a security man. He lost conscious. Is it aura? Is there any aura tumor, alcohol withdrawal syndrome in terms of the diagnosis? You were saying you were a bit too rigid on the empathy and you did not manage concern wholesomely. So these are the things he wanted you to have put in your listing. So meaning you should have asked much about that loss of consciousness. What were the circumstances? What was he told about? And what were the several attacks, the episodes were they associated with aura? What were the post-ictal events and other things surrounding the seizures must have been explored. In a nutshell, I think that was what he's saying. Then he also said maybe use much of the grammar. So I also want to add, I think ab initio, because we are counseling somebody, we want to take as much information from him, most so that he works somewhere, and again, he's afraid of losing his job. So confidentiality, ab initio, is very important. You have to give him confidence that whatever you discuss is going to be confidential. You will not reveal it to anybody unless with his permission. And you have to give him some autonomy that you are here just to guide him. He's one to take the appropriate step. I think that's also very important. Thank you, by the way. So far, there is no any other chats. Maybe we entertain some comments more from our colleagues, senior colleagues, and our teachers.
Thank you, Dr. Yeah, just
Okay, Chief. Hey, okay, good morning, sir. Sir, you can go ahead, sir.
All right, good morning, everyone. Thank you, Dr. Cassidy, for that presentation. It was actually beautifully done. But as usual, when it comes to counseling, there are always many issues, okay? So, and for everyone you give, you are supposed to learn something, okay? So that you get better for the next one, all right? Okay, so one of the things I noted was that you didn't use simple languages as much as possible. You tried a little, but you have to, they told you, in fact, in the question, it was written uneducated. The word uneducated was put there clearly. So if someone is uneducated, you don't expect them to understand many things, and you're using so many technical terms, okay? So you have to break it down. And mind you, this session is not for you to lecture the examiners. You were talking as if you were trying to impress the examiners to make them know that you understand the subject matter. No, that's not your task. Your task here is to make sure that the patient in front of you understands you, understands the situation, understands the condition. And you are trying as much as possible to help that patient. Now, you try to recap once. Normally, you don't recap once, okay? At least 2 to 3 times. 2 is the least that you can do. You tried once, but you did not even do the recap very well. You said, you asked your client if he understood what you have said. And he said, I understood most of it. That's not recap. Recap is tell me what I have told you. That's the recap. So you expect the person to tell you some of the things that you have said. That's the only way you can be sure that the person has understood. But just saying, I understood most of it, no. You'll be shocked when they start telling you, no, I didn't say that. No. You'll be shocked. So recap is them actually telling you what they have understood from what you have said so far. Do you understand?
Yes, sir.
So if they have not done that, then you have not recapped. That's the word. That's why the word is recap. Let them say it, what they have understood, and you will hear it and make sure that it rhymes with what you have said. You'll be shocked that you are telling them your medications, you should use them twice a day. And when you are telling them to recap, you say I should be using the drugs once in 2 days. You'll be shocked. It can be that's different. I'm just using that for an example. Okay, so it's important that you actually do that recap so that you are sure the person is following your thoughts. Then yes, someone has mentioned empathy. I didn't really see much of the empathy, okay? You have to be very empathetic. Remember that this disease entity is one that comes with so much stigma. A lot of stigma. A lot of hide, especially for the uneducated. They want to hide. They don't want people to know that they are having it. There's this stigma. People in the community will say they are this, they are that, they are possessed by the evil spirits, all those kind of things. So you have to be very empathetic, and you need to explain to the person clearly that this thing, please, is not any evil spirit. This thing, the possible cause, you might not know it too, the actual cause, however, it is a problem with the wiring of the brain. So now, when you finish all this explanation, now, how do you actually help him in this place of work? Now, he's worried of drowsiness, that he sleeps, especially when the disease entity can make him to be drowsy. There's post-ictal sleep or drowsiness or confusion. Even the medications. Then he's now taking alcohol again. Another thing is, the person is a security man. In his workplace, does he have to work at night or during the daytime? When are the seizures more frequent? Is it at night or during the daytime? If the seizures come more at night, before you achieve control, can you Can you advocate for him in his workplace for him to be working during the daytime, so that even when the thing happens, it will not affect his job? Or is it possible to even change the job? Things like, does he drive to work? You know, he cannot drive. So there's so many things at workplace. Does he work with things that require moving, that when he sees this can cause bad problems or injuries or damage? His workplace, how comfortable is it? Does he have things that can injure him if he has a seizure? So there are still so many things that one has to do, because you need to protect him and protect the people around him and make sure that he does not lose his job and that he performs to his maximum at the workplace too. So I didn't see you going into this parts of the discussion, trying to help the patient fit into his workplace. Maybe if it's possible to adjust the schedule, and then the alcohol part. And then again, remember that many of the simulators will be told not to give you tidbits. This simulator quickly told you one concern when you were wasting time without asking. You need to ask for the concerns quickly. She quickly told you about her fear of losing the job. You are the one that should tease out this concern without her giving you a lead. Because in the exam, they will tell them specifically not to give you any leads. They will tell the simulator not to give you any leads at all until you ask specifically. Okay, so I think these are some of the things that I can remember. But the other part of the question, you were spot on. Okay, so this one, even though you did well, but you need to improve. Okay, thank you.
Thank you, sir.
Thank you, sir, for coming in and making things very, very clear. We appreciate, sir. Thank you. We still entertain some few comments again before we move to the next presentation. The next presenters could be Dr. Agu, Dr. Ajibola Sanda. So they should get ready, please. Dr. Agu had very busy yesterday. He presented his book. He could not finish making arrangement. However, he can present his presentation like that. But I don't know whether Dr. Ajibola Sanda has prepared for it. He's the third on the list. If he can't, maybe we take his own presentation after this.
Yeah, I'm ready to take my presentation.
Okay. So just get ready in a few minutes.
Dr. Yahaya, before we move to the next question,
yes,
I must commend the last speaker, Dr. Ibe. Thank you so much. It was wonderful. It was a fair attempt. But I will advise you, we have less than 2 weeks to the exam. I think you guys need to practice more your timing. National, as we always say, is different from West Africa. They tend to have voluminous questions. They have a lot of questions. You need to answer within the stipulated time. So you need to work on your time. You actually spent more than 15 minutes answering the question. I know Dr. Agus and all of that, but that was less than 5 minutes. So calculating all of it, you actually spent more than 15 minutes. So you want to be able to finish every station and catch your breath for the next one, because they will practically drag you to the next room. So if you have not relaxed, you are going to the next room, you are going to start speaking again. So try to work on your timing, work on your speed, and look at the questions properly. Our dear Chief Remigus have already highlighted what I want to talk about. They told you this guy is security. They told you he's uneducated. Once they give you a question, if you can, you can always request for a paper and they allow you to go with your pen. Highlight the most important things you want to talk about. Someone that is a security, this guy takes alcohol. You might be taking alcohol to keep alert because he's feeling drowsy. So you put all the key points you want to quickly address. Arrange all of your points in your paper and note that. So once you start speaking, the points are already there. You won't miss any important points. You can use a minute or so, even though it's voluminous, that voluminous question. But use a few minutes, few seconds to quickly organize your thoughts. Once your thought is organized, once you start speaking, if you lose any points, go back to what you already organized and you won't lose out on anything. So that's just what I want to highlight. Thank you so much once again. Thank you.
Thank you, ma, for coming in. Thank you. We appreciate the advice, ma. Thank you. I think in the absence of any other comments, we move to the next presentation.
Hello?
Okay. Yeah.
Hello?
Okay, sir. Come in. Yes, sir.
Yeah, finally, the last what's the last part of that spikes again? The summary and what again? Summary and sure, summary. That last part. Always please don't forget it. Okay, if you want to, if you're using the spikes. One of the most important things is to schedule another appointment as much as possible before you stop. Okay. Always try not to forget it. You can say something like, oh, all right, I know we might not be able to finish the discussion today, but when we see again in 2 weeks' time or in a month's time, we can continue this discussion. Have a beautiful day, Almost always remember that. So the summary also brings about the aspect of recapping and all those things. Okay, so please don't forget that. Thank you.
Thank you, sir.
Thank you, sir, once again. Thank you. I appreciate it. Dr. Sanda, I think you can go ahead with your presentation.
Good morning, teachers, consultants, and my fellow colleagues. So I'll be taking the question 10. So the question states, define clinical audits. What are the components of clinical audits? And give one example of each. Mention 5 steps of clinical audits. Then patients have been reporting poor BP control in your clinic. How do you audit the process? So also define clinical governance and mention 3 ways of data collection in your clinic. And for each, say whether it is prospective or retrospective. So clinical audit, so question 1, clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against an explicit set criteria, which are the standards. And the components of clinical audits include the structure, the process, and the outcome. And under the structure, we have manpower, machine, materials, and money. Under process, we have procedures and practices, and then the administration. And then under the outcomes, we have effect of healthcare provision and cost of healthcare provision. So it says mention 5 steps in clinical audit. So the steps will be prepare and plan. You select a standard criteria. You measure your performance. You want to implement the improvements in the shortfalls you've seen in your setting, and then you want to sustain the improvements, and finally re-audit the process again. So they say patients have been reporting poor BP control in your clinic. How do you audit the process? So I want to run a clinical audit on poor BP control in my process. I want to look what am I auditing. Am I auditing the structure, the process, or the outcome? In this one, I would like to audit the structure. So the first thing is to prepare and plan. I'm preparing and planning. I will like to compile it with the team. In the MOPD, I want to get the nurses who do the patient's MOPD.
Sorry, doctor. I'm confused. I thought the question was audit the process.
How do you audit the process? Okay, sir.
So why are you changing it now to structure?
Oh, okay, audit the process. Okay, so I'll audit the process. I thought it was to just audit the poor BP control in the MOPD. Okay, I'll audit the process, sir.
No, I'm thinking that was the question. That's why I'm asking.
In all honesty, when I looked at this question, I didn't know the word process was meant to stand out. I thought it was just to run a clinical audit on poor BP control.
It's even highlighted. It's even highlighted. It was written in capitals there.
Yes, sir. So I'll audit the process now then. Okay, so to audit the process, it will still be the same outline, prepare and plan. So for my prepare and plan, I want to choose a team, and my team will comprise of the MOPD nurses, the doctors in the medical outpatient departments, the medical records officers who bring out the patient's folder, store the patient's folder, and know how many patients present to clinic every day, the pharmacist who dispense the antihypertensive medications, and then also like we've been told, when you are comprising your team, you want to get those who are directly initiating the care in these patients, those who can make a decision as to the outcome of your audit process, and the patients themselves. So I want to get the hospital administration involved. I want to get the HOD of the internal medicine department involved, the HOD of the cardiology units, the HOD of nephrology units, since they also are they also see hypertensive patients and clinical pharmacology. I want to get the DCST and the CMD on this team, and then also get patient representative as a member of the team. So then we want to choose a topic, and our topic will be good BP control in the medical outpatient department. And we want our objectives to be SMART, which means that we want to get our objectives to be SMART in this patient. So they must be measurable, achievable, realistic, and time-bound, and also specific. So we want to make sure that words like change, determine, ensure, enhance, and improve, increase compliance are used during our outcome. Our aim here is to improve the blood pressure control in these patients within the next 6 months. We want to now get this standard criteria, so we can be using the Nigerian Hypertension Society criteria and look at what the criteria states in terms of how to achieve adequate BP control in an outpatient setting, and look at what we have currently in our own environment, if we have our own SOPs or already outlined, and compare both and see where we are not meeting up to the accepted standard, and try to achieve maybe a 70 to 80% improvements up to the selected standard that we have already decided to adopt, and also the guidelines. So in monitoring in auditing the process of this, we want to say, okay, when these patients come to the clinic, how soon after they present is their BP done? Because we already assume that our structure is already in place. We have enough manpower. Our BP cuffs are okay. We have resources. So we want to see what is the timing in between, or the interval of timing in between when the patients are arrive and their BP is done. Is it done immediately? Do we give them a few minutes to rest so as to have so as not to have a skewed results? And how many intervals do we how many BP checks are done, and what is the time interval in between the BP checks? Also want to see the actual process of the blood pressure being measured. So are the patients seated when it's being done? Are they standing? Are their hands lying below the level of the heart? Is the chair appropriate? Are the patients told to keep quiet during the procedure and not have a conversation? Are they told to be still? As all of these things we know can be co-founders in the measurement of a blood pressure monitor. Also, the cuff, is it placed at the right level? Is it adequate for the patient's hand? Are we using a smaller cuff for obese patients? Are we using a big cuff for thin patients? All these are the things that we will be looking at to measure and see if we are getting the right appropriate standards. Also, we want to look into the patient's management. So we want to first start with the non-pharmacological management of blood pressure control using the DASH diet, weight reduction. Are patients being counseled about what they eat, their weight, exercise? Those who take cigarettes, have they been counseled on smoking cessation and its effect on blood pressure control? And also alcohol. Those who are also on alcohol, have they been counseled? Have they been at the units of the alcohol? Is it being measured, whether it's a male or a female? And also, have they been told to, have they been enrolled in a counseling class on how to withdraw and stop this alcohol? We also want to look at guideline-directed medical therapy from our standard criteria that we have already adopted. So which medications are being used in our own center, and is it what is tailored to our own type of patients? And the medications, are they available in the pharmacy? Are they affordable? What type are we using? Is it the generic? Are we using the generic forms that we cannot ascertain their authenticity, or are we using the brands that we know that are the gold standard brands for this medication? And also the dosing of medications of these patients. So we want to look through their case notes. We want to know if the patient, want to ask the patient themselves, what drugs are you using? We would also be using questionnaires at this point to know if the patients are taking their medications properly and are taking it at the right time, and if they're also adhering to the medications that are being given to them. So like the previous presenter mentioned, we can use any of the listed outlines to measure the patient's adherence to medications. We can do the pill counting. We can do, in hypertension, we don't really do drug assays or biological assays, and then we don't really do direct observed treatment, but you want to rely on what the patient is telling you, and you want to make sure that the patient is giving you good feedback when you're telling them how to use their drugs, the number of medications to use, and if there is a preferred time to use any of these medications, the time to use these medications. So we want to measure our performance. We'll use data collection. In this place, we'll be using questionnaires to measure our performance, and also the case notes. So since we've already instituted some form of approaches in these patients, we now want to monitor we now want to look through the case notes and see the BP recordings that we have been getting to see if we are achieving our set standard of 70% or 80% of the National Hypertension Society guideline. Then you want to sustain your performance, so you want to improve your performance. So regular patient education will come into this place, drug adherence, like we mentioned, availability of the guideline-directed medical therapy should be on ground, training of staff and patients on BP measurements, like we mentioned, on how to take the measurements, the cough, the level at which the hand is, tell the patient to be still, the timing when the BP is done, and the interval in between both timing, and they want to sustain our improvement. So by this time, we would have collected our data, would have presented our data to the management to tell them these are the shortfalls we've seen. We've already written our recommendations that these are the things that we think will need to be improved on and monitored every time patients come to the MOPD. If we notice that maybe our medications, we cannot guarantee the authenticity of the medications, or whether the medications are expired, or whether the medications are not available, would have written all of this in our reports that we are submitting to the management, and the management is also part of the team of this clinical audit. And at the end of this, we also want to re-audit our process and re-audit. So it says define clinical governance. Clinical governance is a system through which organizations are accountable for continuously improving the quality of their services and safeguarding high standard of care, whereby minimizing risk by creating an environment in which clinical excellence can flourish. And the components of clinical governance, we use this acronym RECORD, with the C having two C's. So risk management, education and training, clinical effectiveness, clinical audits, openness, teamwork and communication, OTC, research and development. So they say mention 3 ways of data collection in your clinic, and for each, say whether it is prospective or retrospective. So medical records, which is a retrospective, questionnaires, which are retrospectives, and also clinic register, which are retrospective. Thank you very much.
Thank you, Dr. Ajibola, for being ever reliable most of the times. Thank you. We appreciate your presentation. The floor is open for contributions. Thank you once again. You are number 3 in the list, but you step up, you make your presentation ready. So we appreciate that. Thanks. So any contribution, please? Okay. Nothing from the chat box.
Please, I would like our teachers to please correct the audit process and see areas where we can make improvements. Please, I would appreciate it. Thank you.
Thanks. So,
hello?
Dr. Ifama, yes, sir.
No, go ahead. Go ahead.
Okay. So in the chat box, Dr. Ifama said, "Thank you. Are we supposed to mention ambulatory blood pressure monitoring and mass effects, etc.?" So she was asking, are we supposed to mention that ambulatory?
Well, if I'm to answer that question, it wasn't set in the question. The question they said we should run a clinical audit on the process of blood pressure monitoring in MOPD. I don't think, well, mask effect, yes, but continuous ambulatory blood pressure monitoring, I don't know.
Hello?
Maybe
Yes, sir. Go ahead, sir. Thank you.
The answer to that question is you can do whatever you want if you can defend it. Okay. If you feel it will help the process of achieving good blood pressure control, why not? Okay. So the question is, would it help to achieve your target of better blood pressure control? Would ambulatory measurement help? If the answer is yes, then why not? Okay, so it could be part of your recommendation that the standard somewhere is that they do ambulatory blood pressure monitoring, and this has helped them in so way. So that you would like to do that. So if you're not doing it and you think it will be helpful, why not? Can be part of the audit process. Okay, masked hypertension, we already know that it is deleterious. Which one is more deleterious? Is it white coat now or masked? Masked hypertension is the one that is more deleterious. So, but that one is important. In fact, white coat is also important. What if what the patient actually has, or some of the patients might have white coat hypertension, and that's why you are recording poor BP control in your clinic. So if you can do home monitoring of blood pressure or 24-hour BP or Holter monitoring, that will tell you that, oh, what this person has is masked hypertension. Why not? Thank you.
Thank you, sir, for always coming in. We appreciate that. Thank you, sir. So any more comments? Go ahead, sir. Chief, sir.
Okay, sorry. I'm actually on the road. Hope I'm audible.
Yes, sir, you're audible, sir.
Thank you. So it's one important thing that, so I missed a segment, which is the last segment. I'm sure you talked about re-auditing the process. Right?
I think he missed that, but when he was talking initially, he talked about it.
Yeah, because there's no way we can finish that kind of an audit in one cycle. So the cycle has to continue. Okay, but one other important thing is the question that was asked about doing ambulatory blood pressure assessment. It is very important, and that can actually influence what you kind of get in clinic. For example, we've noticed that some patients, they have their own BP measurement at home, right? So when they come to clinic and their BPs are high and we adjust their medication, give them large doses, and they get home and they assess their BP and find out their BP is lower. When they take the medications, their BP, they're almost entering hypotension. It makes them stop medication. I'm just trying to tell you life experiences. I've seen one of our nurses just called me from our cath lab and said, oh, this elderly woman complains that her BP medication are too much. When she gets home, she feels dizzy. When she takes it, she goes to, she checks her BP at home and she's getting 90/40, 90/50, you know? And so it makes her stop medication. And every time she now comes to the clinic, BP is like 160/100. So the next medical MDM, the next resident that we see will increase the dose again. So it's very intolerant for her. So it's not making her compliant. So you consider it a process. So if you have the ambulatory BP assessment, I think it will give a better judgment to the clinician on how to manage this patient. So it's not just because you want to identify masked or white coat hypertension. It would also help you to kind of adjust the medication doses, which will make patient more compliant. There's no patient that will get home and check his BP at home and is getting 90/40 and want to use the same high dose antihypertensive or even use any antihypertensive. He's going to skip it for many days. And by the time he's coming to clinic again, his BP is already high. So how does it help you as a clinician? Yes, it helps your audit process. If you have that kind of facility to help actually evaluate this kind of patients to check their compliance level. Because compliance is something you mentioned when you were auditing this process, part of your questionnaire process, right? So I think that is a very important instrument for you to actually really enforce that will help your compliance with the patients. Hope you get it, sir. Thank you very much. Then one last thing, important thing is that always remember that at audit station, I don't think you're only going to see one question. There will be other questions. So you should be as fast as possible so that you'll be able to attend to the other questions that would come in that same station. If you only answer the question on audit and there are many other 3 or 4 questions after that audit question, you understand the meaning. So please be as fast as possible in the audit. God bless you. Thank you.
Thank you very much,
sir.
sir.
Thank you, sir, for coming in. Thank you. Sir Chief Remy, your hand is still up. I don't know whether it's the hand you raised before.
No.
Sir, you want to address us again, sir?
Yes. I did not talk. I just answered the question the other time.
Okay, sir.
So, yes, but this one that Chief has, when he talks like this, to say something else is now difficult. But it's okay. I just wanted to raise the point that, one, the presenter actually did excellently well. All right. And although I don't know why he even wrote structure that he was auditing, well, I don't know why he said he was auditing structure when it's actually the process he actually audited eventually. So mind you, auditing structure is completely different from auditing process. The structure is about the buildings, the manpower, the things that are on ground, not how you work, how you do them. The process is how you do the work. Okay, so and that is what you audited, which is fine. I also wanted to answer a question I saw about somebody talking about whether you need ethical approval. Please, you don't. That's one of the biggest differences between clinical audit and research. You don't need ethical approval to do a clinical audit. All right. So I think those are the things I just wanted to point out again. Apart from that, Chief Prof has said most of the other things that I wanted to say. Okay. So thank you and well done.
Thank you, sir, once again for coming in for the second presentation. You've always been around today, sir. Thank you very much. And sir, before handing over to Chief Dr. Christabel, I just want to advise us on some of the presentations we had last week and this week were yet to be posted in the platform, and many of us we require those presentations for our revisions. So please, I urge my colleagues to please do that today. We really need those presentations. Thank you all. We hand over to Chief Dr. Christabel.
Hello, Dr. Yahya. Thank you so much. Hope
Thank
I
you,
can
ma.
be heard clearly.
Yes, ma.
Okay, thank you. Thank you, everyone. It was quite a wonderful presentation today, both presenters as well. I would like quite a lot. I also thank the participants, first of all, for their commitment. As we always said, this set of national guys are quite dedicated, and we appreciate all your efforts. Thank you. May God bless with your efforts and may it result in resounding success. Thank you so much. Then the other participants, Dr. Mamudu, Dr. Yahya, please help me stop the recording. I'm driving. Dr. Mamudu Jaforu, thank you so much. Always love this.